Hello, my name is Ronald Salento, and I'm a family and a psych mental health nurse practitioner. Today, I'm going to talk about antidepressants in primary care. Hopefully, this will give primary care providers basic understanding in initiating, switching, and combining different antidepressants. Okay, let's get started. Before we diagnose somebody with major depressive disorder, we have to do our due diligence and evaluate any medical issues that might have caused patient's mental issues. I will make sure that these labs have been checked. Thyroid panel, CBC, vitamin D, vitamin B12. Sometimes what seems to be depressive symptoms might be caused by anemia, hypothyroidism, vitamin D, or vitamin B12 deficiency. Now, let's talk about antidepressants. The first line of treatment for depression and also anxiety is an SSRI, or selective serotonin reuptake inhibitor. From your pharmacology class, you know that this class of medication makes the neurotransmitter serotonin more available in the synaptic cleft. There are 6 medications in this class: fluoxetine, sertraline, escitalopram, citalopram, paroxetine, and fluvoxamine. I like to start with the more neutral SSRI such as the sertraline, escitalopram, and citalopram, and my favorite is escitalopram. When I say neutral, it means that these medications are less likely to be sedating or activating. If I have a patient who also struggles with insomnia or anxious depression, I would use paroxetine because this medication may be sedating, so the patient will be able to get some sleep and be more relaxed. If I have a patient that presents with depressive symptoms of feeling low and hopeless and has psychomotor retardation, I would like to go with Prozac. But most of the time, you can use any of the SSRIs. I rarely use fluvoxamine because sometimes it is not covered by major insurance carriers. This medication was initially approved for OCD, but I think any SSRIs are just as good for OCD or obsessive compulsive disorder as fluvoxamine. I usually start any SSRI with the lowest dose, and I would have the patient titrate it up or double it up by the second week. For example, I start with escitalopram/Lexapro 5 milligrams daily, and the patient can start taking 10 milligrams by the second week. I always inform the patient that he or she should feel the effect by 1 or 2 weeks, but the full effect will not be until 4 or 6 weeks. 1/3 of patients, remember this, 1/3 of patients who take any SSRI will not respond to the medication. 1/3 will have moderate response to the first SSRI, and 1/3 will have full response. So if one SSRI medication does not work and you have optimized the dose, you can switch to a different or second SSRI. If the second SSRI has only mild or moderate effects, you can augment with one of the following. For those with low energy depression, we can add Wellbutrin or bupropion. This medication comes in extended release and sustained release, and I like to use the extended release that comes in 150 and 300 milligrams. Maximum dose for this medication is 450 milligrams. Wellbutrin is a dopamine and norepinephrine reuptake inhibitor, so there is no serotonin chemical involved here, and that's a good thing. Some patients don't like the sexual dysfunction or weight gain that is associated with serotonin-based medications, so this is a good option. This medication is FDA approved for depression, seasonal affective disorder, and nicotine abuse. There's no mention that this medication is approved for anxiety, but some studies suggest that this medication can be used as anti-anxiety. In practice, I use Wellbutrin to help patients with their anxiety, and I've seen good results. Some patients might be anxious depressed. In this case, we can augment with gabapentin, buspirone, and hydroxyzine. Gabapentin is a glutamate voltage-gated calcium channel blockers. This medication was first approved for patients with partial seizure and usually commonly prescribed for neuropathic pain and restless leg syndrome nowadays. This medication can also be used as an adjunct to SSRI and an SNRI for anxious depressed patients. You can start with 300 milligrams a day and taper it up, and sometimes up to 1800 milligrams 3 times a day. Although I've never seen anybody prescribe it to the max, I have seen it up to 900 milligrams 3 times a day. The second option for anxious depressed patients are buspirone. You can use this as an augmentation to an SSRI or even SNRI, which we'll talk about in a few minutes. This medication is a serotonin receptor partial agonist, which means that, in simple term, it affects serotonin receptors moderately. This medication is good for patients that are depressed and anxious. The only drawback with this medication that it has to be given 3 times a day because the half-life is only about 2 to 3 hours. The third one is a hydroxyzine. Hydroxyzine can also be used to help those patients with anxious depression. As you know, this medication is an antihistamine and it blocks the histamine 1 receptor. The dose range is usually 50 to 100 milligrams 4 times a day. If you have tried 2 or even 3 different SSRIs and you have optimized the dose, but there's only a minimal relief of the symptoms, I would recommend trying medication from the SNRI class. This is serotonin norepinephrine reuptake inhibitors, and basically what it does, it boosts these 2 neurotransmitters in the brain, serotonin and norepinephrine. The most common meds in this class are venlafaxine, desvenlafaxine, and Cymbalta. Besides its use for antidepressant and anti-anxiety, Cymbalta is commonly used to treat patients with neuropathic pain and fibromyalgia. Because of the norepinephrine component of this medication, it is best to take this medication in the morning because it will be more activating, and I've had patients who have problem falling asleep if taking it at night. Some of you may wonder, can I combine an SSRI and an SNRI? If you check a drug interaction database such as UpToDate, combining SSRI and SNRI together gives a category C, which means monitor therapy. I have seen other providers combine these 2 classes of medications before, but I think it is just not a rational polypharmacy, since SNRI has predominant serotonin activity, especially at low doses. Plus, there is potential of serotonin toxicity, so I would recommend not to. After you have tried an SNRI and there's only minimal relief in symptoms, and you have optimized the dose, you can also add Wellbutrin for low-energy depression and or gabapentin or buspirone or hydroxyzine, just like in the case of SSRI. There are new serotonin-based medications that have been released in the past 15 years. They are called serotonin modulators. The first one is vortioxetine. This medication is a partial agonist, antagonist, and reuptake inhibitor, so the mechanism of action is different from SSRI medications. In a large study of patients who had responded to an SSRI but experienced sexual side effects, participants were randomized to switch to either escitalopram or vortioxetine. Patients receiving vortioxetine show significantly greater improvement in sexual functioning than those randomized to escitalopram. This medication is only approved for depression but not anxiety. This medication is comparable to SSRI in terms of efficacy, and I would choose this medication only if I exhausted all the other options mentioned before. The second serotonin modulator is vilazodone. This medication is classified as a SPARI, which is a serotonin partial agonist and reuptake inhibitors. So basically, it boosts the serotonin chemical in 2 ways. It increases the availability of it in the synaptic cleft and acts as a serotonin neurotransmitters in their receptors. There's really nothing special about this medication. It is comparable to SSRIs in terms of efficacy and side effects, although it carries a lower risk of sexual side effects than SSRIs. This medication is good for depressive symptoms, but not so much for anxiety. My take is this will be the last option among the serotonin-based medications. I would say that this is a simplified algorithm of antidepressants. To a certain extent, the side effects profile of each medication will guide your decision-making process. You may wonder why I don't talk about tricyclic antidepressants or monoamine oxidase inhibitors. Although sometimes we still use it in psychiatry, I recommend to stay away from these classes of medications in primary care, due in part to their significant side effects and interactions. Alright, guys, this is it for now. Now you are an expert in treating depression in primary care. If you enjoy this video, please subscribe, like, or share it. It will help me to make more of this video. Thank you.